Hello, my name is Grace Allison and I am one of the patient navigators here at the MMRF. Myself and another navigator today are going to speak with you about caregivers who are an essential part of the team for a myeloma patient. Nice to be with you all today. So, as you all know, multiple myeloma is a life-changing event, and it can be a lot to learn. There have been a lot of great changes in the way it's treated, but the one thing that we like to remind patients and their caregivers is that treatment will be for life. It will have various stages. You may be in active treatment or you may be in just monitoring phase, but it will be for life. And in this condition, the role of the caregiver obviously is going to be very important. And I believe that most of the caregivers will be able to explain that more than us, but the role includes a lot of various functions, helping to coordinate the appointments for patients, facilitating communications between the patient and their care team, assisting in the patient when they, as necessary, with side effects, advocating for them when necessary, assisting them with activities of daily living as needed. And when we talk about activities of daily living, we're talking about things like dressing themselves, feeding, washing, having a shower, those sort of things. So it's a support role, but it varies depending on the need of the patient, obviously. If somebody is very functional, they'll be less required than somebody who's bedbound in a lot of pain, for example. Caregiver has various responsibility, again, depending on what is required by the patient. There's a lot of coordination that goes on when a patient starts treatment initially. So scheduling those, making sure they're on the calendar, making sure the transportation is available, making sure that the research parking ahead of time, all of those aspects. Anything that involves attending appointments that you could help make it easier for the patient, that's very much a part of what goes on every day. Medications. So once the patient is prescribed some medications, there are various ways that those are fulfilled. Sometimes it is going to a local pharmacy, but sometimes they are delivered to the patient, and coordinating all of that can be complicated. And then once they start on the chemotherapy or the therapy that the physician or team has prescribed, then making sure that the patient stays on schedule is very important, especially with oral medications. Maybe helping them set a timer or getting one of those pill boxes for daily use. Those sort of things would help them with their care. Communication facilitator. This just kind of covers everything that involves going with the patient to the appointments, listening to what the team have to say, asking the questions that are required, knowing that when you leave an appointment, it's very important that the center gives you written instructions on who to contact in time of emergency, or even if you have a question to do with side effects or therapy itself. Knowing that this is a communication that goes two ways. This is not nowadays where the physician speaks and the patient listens and there's never a question allowed. It's always a two-way street in terms of communication. Having you there with the patient means that there are a second pair of ears, and that's vital because some research has shown that patients do not grasp everything that is presented, especially in the early days and when diagnoses and prognosis are being discussed. So asking questions and making sure the clarification is there is very important. There are no stupid questions. There are no extra questions that you feel like you shouldn't ask. Just ask them to have clarification for everybody involved. Taking time to make brief notes, that's always very useful. It's useful for everybody. It's useful for the patient. It's also useful for your care team because it speeds things up when they can ask, well, what was the last blood count? What was your last therapy? Sometimes it sounds conversational, and being able to have those answers really helps with the flow. Disease manager. In order to manage this disease, one of the important parts is to understand the whole myeloma diagnosis, understanding the lab results and what they mean, what changes mean, and knowing what the therapy is and what your options are. So that encompasses a lot. So that's where people like your nurse navigator at your treatment center or nurse navigator at MMRF can help with that, giving you some booklets with common testing and giving some information and understanding to bring everybody up to speed. Advocating for the patient, again, we covered this a little bit, but speaking up when necessary. Maybe the patient had mentioned to you something before you went into an appointment or a therapy session, even if you were going into the infusion center. They did not ask that question, then it's good to have a second person to have it. Oh, you were going to ask about what should I eat or what should I drink or whatever it is that the question was. And then running interference means there could be a lot of other people who want to be involved. A lot of time it's good to have one point person who can then disseminate information to others and let them know how to best help. Having too many people asking the same questions or trying to be involved can get confusing and complicated for the patient and for the care team. So having one person designated as the main caregiver, that really helps in this disease. Myeloma 101, we're going to go back over what is multiple myeloma and just give an overview so that it'll be more useful for people who are new caregivers, but it's always good for people who are established as well. Multiple myeloma is a blood cancer that starts in the bone marrow, the place where the blood cells are formed. Multiple myeloma is caused when a type of white blood cell, caused a plasma cell, becomes cancerous, or you may hear the word malignant, and then grows out of control. So multiple myeloma is the second most common blood cancer in the general population, but the first most common in the African American community. There'll be about 35,000 diagnosed annually, and the prevalence and the occurrence when it happens is higher in men than women, and it is a disease that occurs in older age people for the most part. The average age of diagnosis is 69, but the 5-year overall survival is improving all the time, so that's good news. The 5-year overall survival rate is at 54%. There are various things that modify that outcome. We have shown that there are differences in African American community versus the overall population. The presentation can be different. The Black community are twice as likely to develop multiple myeloma, and they have twice the mortality rate. And so we are working hard to change that so that everybody has the same access to care. So multiple myeloma affects your bones, the blood, and the kidneys, which can be confusing because testing to find the ultimate diagnosis can be delayed if it presents in a renal condition or even in a broken bone condition. And a lot of people are familiar with that. And sometimes it became quite upsetting to feel like that was what was going on all along and it took a while to find it. And that's because if somebody has a complaint of back pain, multiple myeloma is not the first investigation that most physicians do. They will attend to the most obvious and then investigate if those steps don't work. So it's not uncommon for us to see patients who had a delay between back pain complaints and finally having some imaging and the bone damage being discovered. Not in every patient are the kidneys affected, and not in every patient are the bones affected, but that is possibility if the disease has been there a while. Some of the common symptoms of multiple myeloma, and again, it may be more obvious looking back on the patient's complaints as to, oh, that was what was going on all along. But sometimes patients end up with frequent infections because they have low blood counts. They end up with maybe shortness of breath due to some anemia. They could end up with pain from the bone damage and the bone injury. And those are some of the side effects that you could see, or the symptoms that people exhibit when they are initially found to have multiple myeloma. So here at the Patient Navigation Center, we focus when somebody has a new diagnosis on making sure that they are on the right track. And that's just one way of sorting through all of the different information that comes in and trying to establish where should we go next. The right track consists in making sure that the patient has the right team. And that's very important. And especially when somebody is originally diagnosed, having a myeloma specialist definitely improves the patient's outcome. And a lot of times a myeloma specialist can be far from the patient's location. So it often happens that a myeloma patient has a local oncologist and then a specialist that they see less often. But anytime someone is newly diagnosed, they can contact us and we will work with them and directing them to an NCI center that sees a large volume of myeloma patients, because that has been shown to improve the outcome of the person. Also, the right tests. There are some standard testing that would be expected to give an accurate diagnosis, and those are very important, and especially initially, because a lot of times as the disease progresses, where the numbers are compared to where they were on initial diagnosis, or when they're undergoing treatment, the numbers are compared to where they were when they started, to determine response. So the right tests and having the right test results are very important initially. And then getting on the right treatment, that is a very individual decision that will be done between the patient and the physician that is looking after the patient. But there are various approaches that can be used. There's no one right way. It has to be tailored to the patient's tolerance and preferences, but there are some guidelines out there that would be considered standard of care. So the testing can be comprehensive, as you know. Not only does it include blood tests that will monitor what they call the myeloma markers, and those are ones that are really going to focus in on the disease and how it's behaving. You're also going to have frequent urine testing. A lot of times they'll ask you to do a 24-hour urine collection, which involves a big jug, and some of you are familiar with that. That is done in terms of monitoring the disease as well. A bone marrow biopsy is important because they're going to be able to do some genetic testing on there to determine what type of mutations they see. And based on those results, it can impact the treatment plan the physician has. And imaging is just an overarching word that encompasses just plain X-rays, as well as more specialized tests such as a CAT scan, an MRI, or a PET scan. PET scan is a head-to-toe scan that will show a physician where the lesions are in the patient's body, and it can be done more than once, again as a type of measurement for response to disease treatment. So a lot of times we get patients who say, well, my test shows this, what does that mean? And a lot of times we have to pull back and say, it's always a big picture. You have to put the results together almost like a jigsaw puzzle. Each piece is put together to get that one big picture. And once the picture is put together, then the physician and the patient together are able to make steps for what is the appropriate therapy. So staging is important, and then treatment and response to treatment also follows the results. You will have the physician explain to you what type of multiple myeloma that the patient has. And that's important to know as well, because it does have implications for therapy. The majority of multiple myeloma have intact M proteins, which are expressed in the serum in the blood test, and then also can be measured in the urine in some patients. And the type of myeloma is determined by the type of immunoglobulins affected. So you could have the physician say your type is IgA or IgG, IgG being the most common. And then they will also give an additional descriptor based on the type of light chain affected. So there are only two of those light chains, kappa or lambda. You may hear the phrase IgA kappa, and that will mean something to the physician and will mean something in terms of treatment plans. Some patients, about 20%, just have light chain only disease, and then a very tiny minority have a type of myeloma that is non-secretory, which means that the blood and urine cannot be utilized to measure how the disease is presenting and how the disease is responding to treatment. And in those cases, they would have to use imaging to determine how a patient is responding to treatment. So multiple myeloma, you will have patients frequently ask, what about my prognosis? And what impacts my prognosis? Many blood tests and results will be used to come up with that decision descriptor. They will use blood tests such as the B2M on initial diagnosis, and also the LDH, and those including the M spike and the free light chain. And the staging is usually used as the revised international standard. And depending on a variety of factors, physician will let you know whether or not we're dealing with a high-risk disease or a standard risk disease. Those are the two categories. So the key points to remember is multiple myeloma is a rare blood cancer that can negatively affect the bones or your kidneys, the bone marrow, leading to low blood counts initially. Multiple myeloma compromises the immune system, and infections are a risk, so infection prevention is very important. And bone marrow biopsies, the testing done in the bone marrow called the FISH analysis gives some genetic information that are used for prognosis information and also serve to guide drug choices or treatment choices. So the right treatment, patients say, how do we know we're on the right treatment? And so some of the factors to remember is knowing that your treatment options are based a lot of time on your myeloma subtype and also on the stage of the disease. It's important to have a discussion with your physician on the pros and cons of each therapy option, because each therapy may not be right for each patient. You're having that conversation with the physician. Do feel free to clearly communicate with the doctor your treatment goals and any concerns, because sometimes a patient may appear to agree with the therapy plan, but then once the side effects become apparent, then they do not continue to adhere to that therapy plan. And so the physician would much rather know up front and as you go along how you're doing, how you're tolerating it, how we need to adjust based on side effects. So constant communication and open communication, not being afraid to communicate with your treatment team, is really important. Clinical trials are also an option as well, and finding a clinical trial can be guided by your physician and then also what's available close to you. So always keep an eye to that, because they are appropriate for any stage of a myeloma patient, not just initial diagnosis, but further down the road as well. So there are various therapies available for myeloma, and a lot of times you'll see the same class of drugs used again and again. Some of the ones, and you may be familiar with them, include IMiDs, such as thalidomide, which was the early precursor, and then also next generation, which is Revlimid, which is the most frequent one that we hear patients are on, and then also Pomalyst in that class. Proteasome inhibitors are available. Velcade is the sub-Q version, and then Kyprolis is the IV, and Ninlaro is the oral version of that class of drugs. Then there are also chemotherapy, which are the older drugs that are not myeloma specific like the first two classes are. So they will have a different side effect profile. Steroids, such as dexamethasone, you're going to see those feature a lot of the time in the combinations that the physicians prescribe. They are important in the combination in that they do have an action against the myeloma, but they also have their own unique set of side effects and challenges. Novel agents are sometimes used, not initially. We see them used usually in a relapse situation. You'll see other therapies as outlined there. Myeloma survival has improved as drugs have been developed. And so that again explains why the overall 5-year survival is improving. And you can see here on the chart, back in the 1970s and 80s, you had a very few drugs that were used and appropriately used for myeloma. And then recently in 2014 and beyond, we have much more available, which is very reassuring for patients and physicians to know that there are options, that there are other ways to go if one line doesn't work. So the goals of multiple myeloma, and this is important because a lot of the times patients need to understand that the disease, while it may never be considered curable, it's still considered an incurable and type of chronic disease. The goal is to reduce the number of myeloma cells that are in the patient, and that is measured by your blood tests and your urine tests, and then eliminating them from the bone marrow so they have an opportunity to replicate. So how that is decided is if they're present or not is when a bone marrow biopsy is sent for a type of testing called minimal residual disease testing, and that will tell us whether or not we have met a definition of stringent complete response versus complete response. It's also important to include quality of life considerations as a patient is going through therapy. And that goes back to having that conversation with the physician if any of the side effects become more than a person can manage, rather than withdrawing from the therapy. Having the conversation to see how those therapies can be modified would be a much better outcome. Providing for the longest period possible of remission or disease response before it relapses, that is absolutely the goal of most myeloma patients, to get into that remission phase and not have to be in active therapy all of the time. And prolonging overall survival, that is obviously what's on foremost of everybody's mind. So if somebody is newly diagnosed, there are certain treatment plans that you're going to see. They are based on whether or not the person is going to be considered a candidate for a transplant or not, a stem cell transplant. And a lot of times those decisions are made up front, and they're based on eligibility for transplant can be decided on whether somebody has appropriate functional status, whether they have other what they call comorbidities. Do they have heart disease? Do they have lung disease? So if they are going to be a candidate for transplant, normally what you'll see is an induction therapy to get to a really good response. And that can confuse some patients because we'll get calls and they'll say, I'm in a remission, why do I need now to proceed to transplant? And a lot of times we have to remind them that this is the appropriate time to collect those stem cells. And at that point, then an early versus a late transplant can be decided upon between the patient and the physician. But the gold standard and standard of care for myeloma is to harvest after several rounds of induction therapy and then go to a transplant, a stem cell transplant. And after the transplant, after about 100 days, the physician will assess response to that transplant and then discuss consolidation therapy. Some of that will include many drugs, and some patients see one maintenance drug. And that maintenance therapy will continue with monitoring of the patient's disease status to make sure that remission continues. And if then there's any evidence of response of relapse, then therapy will be discussed again. If a patient is not transplant eligible, then induction will not be clearly followed by transplant, but they'll move into a maintenance phase once the physician believes that they've had an adequate response from the disease. So those are things to bear in mind. And now I'll hand it over to Brittany, another patient navigator, to bring you further into how multiple myeloma can be treated. Thank you so much for your time.
Hi, my name is Brittany Hartmann. I'm one of the patient navigators at the Multiple Myeloma Research Foundation. I'm going to be covering maintenance therapy as well as stem cell transplant and MRD throughout this recording. So this is the overview of treatment for active multiple myeloma. Your doctor will determine if you're transplant eligible or not, and that will create a roadmap to determine what kind of therapies are available to a patient. If you are transplant eligible, typically you'll go through a few rounds of induction therapy prior to doing a stem cell collection, and then you can move forward either immediately or at whatever point you and your doctor determine is appropriate to do high-dose melphalan and a stem cell transplant. If you're not eligible, you will typically go through the maintenance regimens or other available medications, which we will go over a little bit later, as well as clinical trials. So these are the typical regimens for induction therapy. This is what your doctor will use to determine what medications are appropriate. Usually Revlimid, Velcade, dexamethasone are pretty much the first-line therapy for most patients. Sometimes daratumumab is also included in the first-line therapy. After you stop responding to a therapy or your doctor determines they maybe want you to get into a deeper state of remission, you can go through and see the other medications that are available and recommended to you. This here shows what your doctor will use to see what available options there are. So what is a stem cell transplant? A transplant is when the doctor harvests your cells so that you can reinfuse them as a form of treatment. So these cells are collected using chemotherapy or a growth factor to get the cells able to collect. And then once you do that, they can store the stem cells or they can give them to you pretty much right after the harvest. They'll use a high-dose chemotherapy to get you ready for the transplant. And after that, you will usually be inpatient. Some facilities can do outpatient transplant, but typically you're monitored in the hospital when you're getting the transplant done. So this here goes through the timeline of a stem cell transplant, starting with induction therapy, which is usually 4 to 6 cycles, at which point your doctor will set up for you to collect the stem cells. Usually you'll meet with a transplant team and they will go through all of the steps of what to expect. So that would be a good point of contact for if you have questions about the stem cell transplant. You'll usually have a stem cell transplant coordinator. And after you collect the cells, they'll freeze them. They can stay in storage for years if needed, or be used pretty much immediately after the harvest if that's what you and your doctor determine. You'll then do a high-dose chemotherapy. Typically melphalan is what's used. That will get you ready for the transplant, at which point then your doctor considers it day 0 of your transplant when you get the cells reinfused. The recovery period is typically about 3 months. The first month is when you'll notice the most side effects. Slowly you'll start to feel a little bit better, but typically the doctor will monitor you off of chemotherapy during the first initial 3 months while your body recovers from the transplant. After the transplant, you may be ready for a maintenance therapy. That would be the overall goal of the transplant, is to get to pretty much the lowest possible level of myeloma that you could find, and at which point you would go on to maintenance therapy. So a maintenance therapy is prolonged and low-dose treatment given after the initial therapy or transplant. The goal is to prevent disease progression for as long as possible while maintaining favorable quality of life, and to eliminate minimal residual disease or the absence of MRD, reduce the risk of relapse, and prolong survival. Typically, doctors will want to give you something that is easy to take, an oral regimen, for example, possibly Revlimid is a very popular one, but you and your doctor will determine what maintenance therapy would be best for you. So these here are the typical maintenance therapy options. Again, as mentioned, Revlimid is one of the more popular ones. Also, Ninlaro and Velcade can be used, or any combination of these medications. The way that your doctor will monitor a response to therapy is stable disease, minor response, partial response, very good partial response, complete remission, or stringent complete remission. The goal is to get to complete remission or stringent complete remission, and your doctor will use a percentage of how you respond by monitoring your lab work, your bone marrow biopsies, imaging, all of those in combination, depending on how the particular disease presents, is how the doctor would determine what your response to therapy is. Though it's a goal to get into complete remission, not every patient will do so, but this is how the doctor will monitor how you're responding to a therapy. What is minimal residual disease? The presence of small amounts of myeloma cells left in the bone marrow following the achievement of a complete remission after treatment. Minimal residual disease tests can detect at least one cell in 100,000 or better. Ideally, we want to use more sensitive assays that can find one cell in a million. So the overall goal of treatment at this point is now to try to achieve minimal residual disease, which essentially is saying that you have the least possible amount of myeloma detectable after your induction therapy, possibly stem cell transplant if eligible, and then your maintenance regimen. And the maintenance regimen, if you are MRD negative, that sometimes can determine how long you'll stay on a maintenance regimen for. If that shows that it's working, then typically you'll stay on it for at least a few years, but you can discuss with your doctor what would be best for you. The key terms for MRD: MRD positive shows that myeloma cells are still detectable. MRD negative shows that the cells are not detectable. Patients who achieve MRD negativity following treatment live longer than those who are MRD positive. So because of this, this is the overall goal of myeloma treatment, is to try to achieve MRD negativity. So this goes into the main systems affected by myeloma treatment. Myeloma patients are at increased risk of developing blood clots. Most of the regimens will require you to be on some sort of anticoagulant, whether it be a low-dose baby aspirin, or if you have a higher risk, you may possibly also need to consult with your cardiologist to determine what medication would be best for you to prevent the risk of deep vein thrombosis. Peripheral neuropathy is also a very common condition. It affects the nerves, resulting in pain, tingling, burning sensations, numbness in the hands and feet. Many myeloma treatments, including Velcade, which is one of the first-line therapies, can cause neuropathy. Sometimes it can be irreversible, so if you start to notice this, then you should definitely speak with your doctor, because there is a chance that they may adjust the dosage of the medication if you're responding well. Or also you can take medications that help combat the peripheral neuropathy, such as gabapentin, Cymbalta. Other times it may be vitamin deficiencies. Your doctor can run a peripheral neuropathy panel to see if there's any deficiencies that you may be able to benefit from taking supplements. There's also cardiovascular side effects, including high blood pressure, congestive heart failure with some multiple myeloma drugs. Of note, carfilzomib is one of those that has high cardiac toxicity. So that's something that your doctor will want to discuss. If you have any prior cardiac history, that's something that should be monitored very closely. And again, consulting with your cardiologist, if this is the drug that your doctor would like to choose for you, is something that would be beneficial. As well, some multiple myeloma drugs cause a variety of gastrointestinal problems such as constipation, diarrhea, nausea, vomiting. You would want to discuss this with your medical team, as most of these are manageable with lifestyle changes, other medications, hydration, activity. So this is something that you would want to discuss with the doctor if you're experiencing that. So most medication regimens for multiple myeloma include a steroid of some kind. So steroids have quite a few side effects that can include insomnia, fluid retention, mood changes, heartburn, and high blood sugar. Your doctor will monitor for all of these symptoms, but if you are experiencing them, you should speak to the doctor because, again, sometimes a dose adjustment or other medications can help combat these side effects. For insomnia, it's important to have healthy sleep habits, timing, and if needed, medications to help with your sleep. For fluid retention, it's important to monitor for swelling and puffiness, monitor for weight changes and weight gain. Again, this is a situation where we may want to reduce the dose of the medication and you notice that the side effects become less. Mood changes are also very common with steroids. They can cause some irritability, anxiety, difficulty concentrating. So if you do experience this, it's typically a little more noticeable the day of or a few days following the steroids and tends to taper off. But if it's something that is impacting day-to-day life, again, speak with your doctor. Heartburn can be very common with steroids. You can make some dietary modifications. Again, avoid spicy or acidic foods. Avoid NSAIDs, which is recommended with myeloma anyways because of the kidney protection. You can take an anti-acid medication. Make sure to always speak with your doctor before taking anything over the counter to ensure that there's no interactions with your current regimen. And it's also important to take steroids with food because that will help decrease the irritation. Typically, again, going back to the insomnia, you'll want to take this medication in the morning with food, so you may want to take that with breakfast if you're taking this at home. And sometimes the medications can be given at the infusion center, so just make sure you speak with your doctor about when you'll be receiving the steroids. And lastly, the elevation in glucose. Steroids can increase your appetite as well as cause elevations in your glucose, but that should be monitored by your doctor through the blood work whenever you go for your infusions. So when determining your personal treatment plan, speaking with your healthcare team is a very important part of this process. Your overall health and characteristics of myeloma will be a big determination of how your doctor chooses what kind of treatment plan would be best for you. Age and general health, other conditions, test results, and symptoms may be something to consider, as well as your personal preference and goals, eliminating versus controlling the disease, willingness to tolerate side effects, symptom relief, personal and lifestyle situations. So for example, if you did want something that you did not have to necessarily go to the treatment center multiple times a week or weekly, you can discuss an all-oral regimen with your doctor. But in that case, the goal may be that it's more of a disease control versus elimination, since it has been shown that more robust treatment regimens, quadruple therapy, triplet therapy of multiple medications do tend to have a better outcome when it comes to disease control. So after induction therapy and either stem cell transplant or if you're not eligible for stem cell transplant, going on a maintenance medication, there will be a time where the myeloma will likely relapse, as this is a disease of relapse and remission. So this is an expected part of the course of myeloma. What is relapsed refractory disease? Relapsed means recurrence or reappearance of the disease after a response to therapy. Refractory means progression despite ongoing therapy. Progression shows a change in M protein light chain values. And line of therapy is a change in treatment due to either progression of disease or unmanageable side effects. When determining how to choose a therapy for a relapse or refractory myeloma, it's a similar kind of thing to when you choose induction therapy. Your doctor will look at what options are available to you and measure your disease specifically. So things that they may want to consider is what prior therapies have been used, how well did it work, did the myeloma progress on active therapy, does the patient have high-risk cytogenetics, what else do we know about the patient, age, other medical problems such as diabetes and blood clots, lasting side effects of past therapies such as peripheral neuropathy, and personal preference or value. So upon first relapse, the doctor will use this as a guide for how to choose the next treatment. Typically, the first relapse, you'll have a proteasome inhibitor, an IMiD drug, and an antibody-based therapy. This is a list of all the available drugs currently for relapsed refractory multiple myeloma. Again, your doctor will take a look at the specific disease of each patient to determine what would be the best combination of medications to best control the disease. Along with already approved medications, these are the options on the horizon. These are clinical trial options that you can speak with your doctor about if that would be a good fit for you. These are not FDA approved at this time for myeloma, but are in phase 1, 2, and 3. You can get more information at clinicaltrials.gov. So these are some key points from this presentation. Relapsed refractory myeloma is treatable. Patients typically receive multiple lines of therapy. Treatment is almost always continued for an extended period. There have been 11 new drugs approved and available in the last 9 years. With the introduction of each new drug, there is a potential for new combinations. Many promising new drugs and combinations are in clinical development, and you can consider a clinical trial and speak with your doctor about that as an option as well. So in conclusion, we've discussed maintenance therapy, stem cell transplant, minimal residual disease, and relapsed refractory disease. This is the typical progression of myeloma, but each patient does have a bit of a unique journey, so it's important as the caregiver to know what to ask the doctor. Educating yourself on the disease process itself, what available treatment options there are a way that you can support the patient. To support the patient, you should know what to expect, assist with decision-making, help maintain a degree of normalcy, and understand the patient's fears, anxieties, and frustration. It's also important as a caregiver to take care of yourself, as you will need to be taking care of yourself to be able to support the patient through this myeloma journey. So it's good to pay attention to your own needs. Don't be afraid to ask for help. Learn more about multiple myeloma and look for the positive. There are great options like support groups that you can find in your area, many of which you can still join virtually. The MMRF does have a search function on the website to look for support groups, and that would be a good way to make sure that you're supporting yourself and the patient. So some key factors to maintain normalcy in daily living, as well as support overall health, is proper nutrition, exercise, rest, and social contacts. For more information on resources, you can visit the mmrf.org/resources/education programs. There are a lot of great videos, printable materials, download materials that you can reference at any time. Additionally, if you have any questions, concerns, or just need some support, you can reach out to the Patient Navigation Center at 888-841-MMRF, which is 6673. So again, that is 888-841-6673. There's also an option if you go onto the website that you can fill out a web form and someone can be in touch with you via email. Thank you very much for your time.